Good morning and welcome to the UofL Neuroscience Grand Rounds. I am Carrie Rimmel, Chair of Neurology, and have the pleasure of introducing our distinguished speaker, Dr. Marcus Stoddard. Dr. Stoddard has been at UofL for many years, but he did his medical school training at Johns Hopkins. Then he did his residency and fellowship in Cardiology at St. Louis University. He has been the medical director and clinical chief of cardiovascular surgery at UofL for many years, and he has many distinctions, one of which is he's well known in the region and nationally for being a guru in echocardiography. He is the fellowship director in cardiology as well, and is a leader at the VA, UofL, and in the community. We are so happy to have Dr. Stoddard here. I just have to say one other little thing. When I started on faculty in 2000, he had been here a while and, and taught me, probably didn't remember that, but he was probably a little bit leery about stroke and me because I was such a fan of TEE. But anyway, we have evolved over these years and are a great friend and colleague. So I appreciate Dr. Stoddard giving us grand rounds on the role of echocardiography.
Thank you, Carrie. I do appreciate all those nice comments. I had a little elevation in my role, but I'll correct that later. But listen, this is going to be a great day. I think I always get supercharged when someone asks me to speak on stuff I do with passion on a daily basis. And so I'm going to welcome you to my world a little bit, maybe too much more. Hopefully some of the fellows in cardiology are here as well. I'm sure they will dive right into it. But this is an important topic. And I think that how we approach these patients who have had potentially ischemic strokes or imaging, cardiac imaging, may vary. At this institution, Carrie is absolutely right. It's been a very appropriately aggressive use of echocardiography in general, and certainly transesophageal echocardiography, trying to really change the natural history of these patients, right? That's really what it's all about. And also, we as cardiologists utilize echo, particularly TEE, in a preventive role too, as we try to determine, is this patient going to be a candidate for a Watchman procedure? That's one of the highest items that's occurred, for us at least as cardiologists, for primary prevention of stroke and non-valvular AFib. But let's start at the beginning. The focus is ischemic stroke or potentially thought of as ischemic stroke. There is also cardioaortic embolic stroke coming from the heart for clots and things in the aorta, and cryptogenic stroke. That's really where the role of TE and echo would play a major role, with percutaneous PFO closures now possible. And AFib, I've carved that out as sort of a secondary, almost a second talk in a sense, but it really fits into the same talk. And namely the secondary prevention, and particularly in patients who have had recent strokes. That is, I think, what the neuro stroke doctors have primarily had in their management. Patients with prior AFib presents with a recent or new stroke. I think that's when they primarily see their AFib patients. Primary prevention of the AFib patient may be a little bit less common for them to have consults or in that agenda, but we see them as well. Ischemic stroke accounts for 87% of all of our strokes. Cardiac aortic embolism is another 20%. Of the ischemic strokes, 20% come from cardiac aortic sources. Cryptogenic is still a large percentage of the ischemic strokes, 30%. And that's the individuals who, without a diagnosis being rendered, their outcome can be worse for recurrence of strokes than those who have a potential treatable option. So that cryptogenic population is very important to carve out, particularly potential impact that echo may have. Cervical, cranial, arterial atherosclerosis are 20% of ischemic strokes, not something that echo would have a particular role for. And small vessel occlusion, 25% of ischemic strokes. So 50% or more of these ischemic strokes, you can see just from the numbers, echo should have a potential diagnostic role as we look for potential etiologies. But not too fast. I find, this, I was talking to one of my fellows, I said, how many different causes of stroke could you list? And I won't mention the name. She said 5 or 6. I said I could list at least 25 off the top of my head. And she was floored. How's that possible? 25 causes of stroke. Well, in fact, patients don't come with on their chest labeled that this is the cause of their stroke. It could be a whole host of things, multifactorial. But take a look at this list, and I won't read them out to you and absorb this. I just wanted to emphasize a few things on this list that may be a little bit less familiar to you. One is dysfunction of the left atrial appendage, independent of AFib, also independent whether you have thrombus or not. So we have on our report started to comment on left atrial appendage systolic function. So I would have our stroke doctors heed that and factor that in. Also, this phenomenon of intrapulmonary shunt, something that we recognize at UofL in one of our research studies, that intrapulmonary shunt is a potential facilitator, we believe, of cryptogenic stroke. And these other areas, the superior vena cava, the inferior vena cava, the pulmonic vein, I think that these are areas of stasis, and they may predispose to thrombus formation and also need to be reckoned with, particularly in a cryptogenic patient who you have no clue what's happened, and you may have stasis in the IVC. And there may be other portals of entry to the left heart, such as intrapulmonary circuit. Food for thought right now. Well, this is a study we did years ago. It looked at the impact of transesophageal echo in stroke patients and TIA patients. It was 200 patients with non-hemorrhagic stroke or TIA, predominantly stroke. This mean population of patients were middle-aged, 61. Whole host of risk factors: hypertension, 90%, diabetics, 31%, hypercholesterolemia, 22% of our patients had it, and tobacco use was 80%. I remember when we presented this paper, the reviewers went crazy. How can your patients be 80% smokers? And it was absolutely true. We went back, looked at the numbers, and we said, our patients live in Kentucky. It is 80%. Sorry, that's what it is. And so that was the baseline patient population. Obviously, high risk for thromboatherosclerotic events. AFib did not represent a huge percentage of the population, but it did not exclude AFib or flutter patients, 8.5%. So predominantly a non-AFib population. And Dr. Don was one of my fellows that helped me immensely on this study. We want to know that were the doctors utilizing the information from the TE. In this population, one or more risk factors for stroke was found in 58% of the patients. Thrombus, stasis within the left atrium, myxoma, PFO, septal aneurysms were a hot topic at the time. Severe arch plaque, these were sort of things that were found, 58%. The treatment was changed on the basis of the TE findings and 29% of this population. So in fact, in this subgroup, patients were being impacted in their care based on the TE findings. Either anticoagulants were started or stopped, antiplatelet therapy was started, antibiotics may have been started or stopped on the preconception of endocarditis, and cardiac surgery was needed in a small subgroup, patients with myxoma. Other things were downstream effects. Further diagnostic testing was prompted on the basis of TE findings or canceled if a definitive cause was already found in about 14.5% of patients. And interesting enough, patients were found to have vegetations, 21, 9 of which had positive blood cultures. And this 9 patients did not have a suspicion of endocarditis prior to the TE. So the point is that TE findings did have a substantial impact, at least in patient management and diagnostic workup. The huge question, though, did it improve outcome? There's really no outcome data that I'm aware of, but at least we know there is a management clinical treatment impact in these patients. Another study consistent with this as well was by Kent Sanos in 2016. This is a cryptogenic stroke population. And what was found here, one or more TE findings of an embolic source was found in 69%. So very consistent with our original study. Thrombus, stasis, myxomas, PFO, septal aneurysms, severe plaques. And I didn't want to go through the full laundry list of all the specific things that any of those 2 studies found, because it becomes very exhausting. But any one of those things, and even more that's not even listed there, was found in at least one of these entities in 69% of patients. Treatment was changed on the basis of TE in 9% of their patient cohort, predominantly with anticoagulation being started. These are patients whose thrombi were formed or seen and was not initially suspected. And like our study as well, cardiac surgery was needed in a small group of patients who had masses that turned out to be tumors in that population. So yes, TE does have an impact. In this study, treatment was changed to 9%, a bit lower than what we've had in our study, but that's the predisposition. So here's the problem. This is a left atrial appendage, large mobile thrombus. The left atrial appendage is dysfunctional. It doesn't contract very effectively, and you have this large thrombi. So that is an essential focus in these patients with ischemic stroke, potential cardioembolic source, when we're looking for imaging. Almost as high a risk for subsequent stroke in these patients are those who not only don't have necessary clots, but have this very dense, spontaneous echocontrast. This is a manifestation of stasis. The red blood cells are stacking amongst themselves. The rouleau formation with the red cells now becoming able to be imaged on the echo. So this is what we see, and you have a dysfunctional left atrial appendage. The spontaneous echocontrast you'll see listed in the echo reports. And we'll try to give an idea of what is the risk of the left atrial appendage leading subsequently to stroke. And it'll be based on systolic function, size, based on the development of spontaneous echocontrast, and of course clot. So you'll see that sort of prediction trying to at least influence or play a role in your thought process about what may have caused this patient's stroke and what may be necessary for further stroke prevention. So certainly look out for that element in the TE reports that you will look at. This is another good example of spontaneous echocontrast. This is the left ventricle. This whole area appears the left atrium. It's dilated, and all this brown swirling smoke-like stuff, when we call it smoke, is spontaneous echocontrast. So this tremendous stasis of blood flow within the left atrium. Obviously, the left atrium is a key element, we believe, of cardioembolic strokes and thrombus formation. So obviously, there's going to be a focus on imaging the left atrium by echo. The three-dimensional element of it really makes it very nice and improves the sensitivity, not only for spontaneous echocontrast, but also for thrombus interrogation. And we'll come back to that in a moment. But there's many numerous causes of stroke that have nothing to do with the left atrium. And on that initial slide, I put the 25, I don't know how many causes there were. You can see that the left atrium was a minority in terms of the listing of it. Obviously a big predominant cause overall, but there's other things that can lead to cardioembolic stroke that are important to look for as well. And cardiac imaging then will play a role, particularly echo, and particularly transesophageal echo. So what I've had here is a three-dimensional display of large atheromata within the aortic arch. And these atheromata are high risk for thrombus formation. And what we're seeing here is a mobile thrombus attached to this atheromata. Now, early on, we were sort of a little squeamish about calling this a thrombus. Maybe it's just mobile debris. Maybe we're overcalling thrombi. But actually, pathological studies have well confirmed that when you see this type of mobile debris on plaque formation, this is almost all the case thrombi. So we're pretty confident in saying that this is a mobile thrombus. And that's important. Why? If you look at recommendations for how to treat atheromata, fixed immobile atheromata of the arch, say from the American Stroke Association, American Heart Association, they recommend aspirin and hydrostatin therapy. So that's not the TE finding of that. With that recommendation would probably not be a major finding because many of these patients, of course, if they can use it, are going to be on statins already. And aspirin is a common, or antiplatelet therapy is common. But what they don't talk about is the mobile components. And I think that this is then a potential treatment role for anticoagulation when you have these very high-risk mobile thrombi associated with the atheromata. So clot formation then I think could, with imaging, then make a significant impact in how management is for these patients. And as usual, there's technical errors. Let me see if I can get this slide to advance. All right, it likes me again. Great. So other non-left atrial causes of stroke. Obviously, the left ventricle with thrombus formation. Here, this is a transthoracic three-dimensional imaging, mitral valve, LV cavity. The apex is practically akinetic, and this large mobile mass, which is the thrombus. So we know that this then is a high risk for subsequent embolization. Transthoracic echo is excellent in looking at the LV apex. You can do it also with TEE, but you have to have a very dedicated approach to really look well at the left ventricular apex during a TE procedure. But just other non-left atrial causes. This is an important one, a PFO. You see this big blast of bubbles traversing from the right atrium here into the left atrium across a PFO, and just displayed with TEE three-dimensional imaging. Provocative maneuvers are being done to increase your right atrial pressure, to drive the bubbles across into the left atrium, to increase your sensitivity. There's a lot of ways to look for this type of intracardiac shunting outside of echo. There's transcranial Dopplers. There's other competing modalities, and those are great. But there can be non-specificity in whether the shunt that you saw in a transcranial Doppler actually came across a cardiac source or was, say, intrapulmonary. So with echo, you see a direct site of entry, and you know that that's the source of the of the shunting. So I think it gives you much more specificity. So this is a very good example, and we'll talk a little bit about this as we go on. Here is an interesting case that we actually put in the literature. The images are now degraded. This is several years ago, but this is a large tubular thrombus traversing a PFO. So this is showing what PFOs have the potential to facilitate, namely the transfer of clot that enter the right atrium across to the left atrium for a cardioembolic source. And this is the site of the PFO. Actually, not too many of these are reported in the literature. You would think there'd be a whole lot more, since we feel that PFOs are coupled to paradoxical embolization, but actually catching it in the act is not all that easy. So clots come and they go. This is tubular, probably came from a leg vein. So this is why deep venous thrombosis is certainly one of the things we look for. But I'm going to try to expand your thought process on paradoxical embolization beyond just looking for DVTs into the arena of looking for stasis in other veins, the SVC, the IVC, things we can do on TEE. What about PFO, whether closing makes any difference in stroke outcome for recurrent stroke? These are patients who had cryptogenic stroke. The first two large trials, Closure 1 and the PC, were negative results in 2012, 2013. But subsequent long-term follow-up in the RESPECT trial, the closed trial, and the reduced trial showed, in fact, percutaneous closure of well-selected patients with PFO with previous cryptogenic stroke did impact the outcome in reducing stroke risk over time. Here's the extended RESPECT trial data. Over a 6-year follow-up, PFO closure was better than mere medical therapy, which would be anticoagulation or antiplatelet therapy, with strokes recurrence of 3.6% versus 5.8% in the PFO closure group. In the closed group, 0% of patients had strokes who had a PFO closure, subsequently over a span of 5 years. Hazard ratio of 0.03. In the reduced trial, similarly, we had a marked reduction in stroke in patients who had PFO closures. And this is then, if you're not interested in statistics, one way to look at this is just take this hazard ratio, divide it into 1, and that's the relative risk reduction. So 1 divided by 2.23 would probably go in there 5 times. You have 5 times less risk of stroke with a PFO closure in patients who had cryptogenic stroke at presentation, who are young, less than 60, and would have PFOs. When you combine all of those trials into a meta-analysis, which is displayed here, the outcomes were still more favorable for device closure, even taking the initial trials that were negative. 2% event rate in those who had PFO closure versus 4.5%. So that is a substantial risk reduction. It also shows you one other thing too. Even though you reduce the risk, there's still patients having stroke despite PFO closure. Whether the PFO failed, the closure failed, in some cases, 4%, you may not have complete closure of the shunt. But there's other sources of stroke in cryptogenic stroke. That's really what I think it points out. And it also points out to me that you need a comprehensive test that looks at all these possibilities, not just focusing on PFO alone, looking for all other possibilities that may have a way of causing stroke independent of what your primary concern may be. So I talked about selection. These patients in the latter three trial, closure, and the respect extended follow-up, they chose patients who had fairly substantial PFOs. PFOs that were greater than 3 millimeters were part of the potential criteria. Those with hypermobile septums of the atrial septum and significant right to left shunting. This is a saline bubble study during TE with the right atrium being pacified with saline contrast, and you see the bubbles entering the left atrium with, this is just quiet respirations. You see them gushing through. My point about this is this. I think there certainly should be a comprehensive and collaborative role, not just looking at a TE report and say there's a PFO, let's close it. We need to enter in with the imaging cardiologist as well as the interventional cardiologist to see if that's the appropriate treatment for this patient. The stroke doctor brings so much expertise as to what others the potential causes. The imaging doctor, of course, brings what is the potential feasibility of doing the procedure and also the likelihood that this could have been an anatomical reason for the stroke. And obviously the interventionalist and structural doctor brings that in as well, but also the expert technique in performing it. And I think that combination among other modalities too are helpful in making that decision. This is just so you can see what it looks like. This is an amplastic closure across the atrial septum on 2D. Color flow Doppler looks for a residual shunt. There was none in this patient. This is a 3D rendering, so you can sort of see it a little bit on edge across. You have a larger amplastic ring and a smaller one inner, and this is looking on FOS downward at this amplastic ring. Couple things. It's not a small device. It's fairly large. And this device was originally developed for ASD closure, not PFO closures. And you can see why the design would be ideal for a hole, but a PFO is more of a tunnel, a channel-like tunnel. And you do need a large enough device to close off the whole track, the channel that you see with the PFO. The recommendations from the American Heart Association and Stroke Association in 2014 that consider a PFO closure when you have recurrent DVTs in a patient who have had a previous potential paradoxical embolus. Clearly in need of an update. And this was based on the earlier trials that were relatively unremarkable in terms of impacting stroke subsequent outcome. Now with these other trials that I've showed you, this needs an update. And these patients, I don't think you need DVT there. If you have stroke neurologists who feel that it's cardioembolic, they're not finding DVTs, that's fine. But these patients have a significant PFO by imaging. I think then that is a patient who has anatomical reasons to consider closing the PFO, and we need to update these guidelines, in my opinion. Here's another source of stroke unrelated to left atrial thrombi, and this is an important one. I believe that you need to consider. It's intrapulmonary shunting. Contrast filling up the right atrium and gushing through now the left right upper pulmonic vein. Watch intermittently, you'll see these bubbles gush out of the vein into the left atrium. This is a potential facilitator of stroke, as now right-sided clots that are small enough can traverse these channels in the pulmonary circuit and make it to the veins. These are not 10 capillary channels. These are 60 to 160 micron in size, normal channels in your pulmonary vasculature. Normal channels in your pulmonary vasculature exist, allowing for these bubbles to go right to left. So this is not an AVM. This is physiology that occurs under different situations in the normal pulmonary vasculature. So this is another potential facilitator of paradoxical embolus. This is a study that we did. We looked at patients who had stroke, non-hemorrhagic. There's a gender breakdown. We found 22% had intrapulmonary shunting compared to age-matched controls, as opposed to PFOs, which are slightly higher in this group. And the combined intrapulmonary shunt or PFOs were 42%, and intrapulmonary shunt was 22%. And this is the patients presenting with potential paradoxical embolization. It's another type of physiology to deal with and to think about if you're rendering care to these patients. In a subgroup analysis that we did on patients with cryptogenic stroke or TIA, 71 patients compared to their age-matched cohort, a little bit younger than the overall group. There's the gender breakdown, predominantly male. 35% had intrapulmonary shunting, as compared to 7% of the controls, who had no previous history of stroke. So almost a 5-fold increase in this phenomenon. And it was determined to be, by statistical analysis, an independent predictor of stroke or TIA overall in this cryptogenic cohort. And the odds ratio was 6 times more likely to find intrapulmonary shunting than not if you've not had a stroke. So it's something to consider. Also, from an imaging standpoint, something to make sure of is not the cause of bubbles entering the left atrium, and because it could be missed and misdiagnosed as a PFO. I've learned over the years areas of stasis by imaging. One area of stasis is the inferior vena cava. These are saline bubbles. And this is the IVC on 3D, superior hepatic vein. Notice how these bubbles just sit around back and forth in this IVC. They don't want to move along. This is an area intrinsically of stasis in the cardiovascular system, and a predisposition for thrombus formation, particularly if you have a hypercoagulable patient. May not be in the deep veins, may occur in the IVC. Same thing for the superior vena cava. It's an area where bubbles hang around, you have stasis. And in fact, in this case, you can see these little strand-like items. These are string thrombi that we see often, not often, but intermittently in the SVC. Then another source that echo imaging, particularly TE, could discover as a potential paradoxical source of embolization. Here's actually clots that formed in the superior vena cava and extended down from the SVC into the right atrium. There's a second patient who had also a clot in the superior vena cava that entered into the right atrium. And I said left atrium, but this is right atrium. So a setup for paradoxical embolization if you have a PFO or potentially intrapulmonary shunt. This was one that probably developed on a catheter. You can see a little hollow lumen almost in this clot. This one was de novo. So probably an area of stasis. Maybe a patient had a greater hypercoagulable state or a predisposition for clot formation. You take the normal potential for stasis in the SVC, then you get clot formation. Here's one you may not have thought about in the past. This is pulmonic vein. This is clot within the pulmonic vein that you can see on TE there. If you look very carefully, you see a string-like mobile debris into this pulmonic vein. It's three-dimensional imaging. These things whipping around are actual string thrombi within the pulmonic vein. So in addition to the IVC, SVC, the pulmonic vein is a higher risk for stasis. And so these are areas that cardiac imaging can look at. So my point about imaging TE, when a patient comes to us, we're going to do a comprehensive look for these potential culprits for paradoxical embolization. And I think that sets up TEE in particular. Echo also has a role for looking comprehensively in your stroke population for whether this could be a potential source, in particular your cryptogenic population. So right on time, halfway through, I wanted to shift gears a little bit and talk about AFib, because AFib obviously is a special animal in the stroke arena. One for secondary prevention, patients who presented with stroke, who already have AFib, something that our stroke neurologists see on a frequent basis. And also for us as cardiologists, primary prevention. Is this patient with AFib at risk for bleeding or falls and so forth? Should that patient be treated with anticoagulation in the primary prevention? And sometimes remote secondary prevention, stroke a year ago or 2 years ago. We see those sort of patients often. And this development of these closure devices is going to make this job a little easier in treatment decisions, because now the Watchman device has emerged as an effective stroke prevention option in these patients. All right, so let me answer this question, because that was one of my tasks. Do patients with atrial fibrillation and stroke require cardiac imaging, namely echo and TEE, or even other types of cardiac imaging? And at first glance, it's a little bit counterintuitive. You would think if you have atrial fib and you've had a stroke, then obviously you want to anticoagulate. So what is the cardiac imaging going to bring you further for that patient? So we'll talk about that a little bit, but I think there's still a role. These patients with AFib and a recent stroke are at high risk to have left atrial thrombus, particularly in the left atrial appendage, and that may make an impact on your long-term management strategy of that patient. Anticoagulation in an acute stroke patient with AFib is often delayed because of the concern of hemorrhagic conversion of an ischemic stroke. We did a study called the ARREST trial, and it was several centers. It was done on the notion that patients who come with a stroke with AFib, often anticoagulation could be delayed 3 days, 7 days, on the concern of risk hemorrhagic conversion. I'm not going to talk about that study, so I wanted to talk about it just a little bit here. And the notion was we could use agents like apixaban, who've shown to have less hemorrhagic stroke in general in the AFib population chronically than that of warfarin. So why not push up the time frame of starting anticoagulation of a patient who presents with AFib and a stroke? And that's what the ARREST trial was able to show, that it was safe and actually did benefit. There were less strokes in patients who were given apixaban versus delaying warfarin use. Now, that's a little bit disingenuous in a sense, or misinformation. I'll tell you why. At this center, at the University of Louisville, we have aggressive stroke doctors. They are doing things and starting anticoagulation well within the window of being early, independent of the use of apixaban. So when we tried to do the study, one of the things we ran up against was that our stroke doctors were aggressive in using anticoagulation, didn't want to delay it. So these were some of the things we noticed. So at other centers, they were following other guidelines about delaying it. So, but I think in the patients who are concerned about starting anticoagulation early, TE showing clots obviously would move up the agenda for starting your anticoagulation sooner, certainly at other centers. Transthoracic echo remains useful. TE is comprehensive, as you've seen a little glimpse of. And there's other imaging modalities of the heart, too, that can play a role in select patients. AFib is the leading cause of ischemic stroke in about 25% in general. And you see as you get older, as you get out to the 90-year quartile, 45% of ischemic strokes are from AFib or associated with it in women, and over 40% in men. So the point about this is that in the elderly population, imaging is going to be even more important, particularly the left atrium, as a potential source of ischemic stroke. So I really think even the older patient benefits potentially because their risk for having the various things they're concerned about are higher as you get older, tercile by tercile. The site of the stroke, the clots in these AFib patients, these non-valvular, even valvular AFib, particularly non-valvular, is often the left atrium. 75% are likely coming from the left atrium as a cause for ischemic stroke, over 75%. So it stands to reason that imaging the left atrium is going to be key. We're going to focus on the left atrium, and the left atrial appendage in particular, as we try to bring down the overall stroke risk over time, and imaging with TE can be very helpful. Here's a 3D image looking down on the left atrial appendage. You can see the 3D mobile thrombi within the left atrial appendage. 3D offers another armamentarium to interrogate the left atrial appendage and looking for a small clot formation. But the point of this slide is an important one. If you look at different AFib patient population, those coming for cardioversion, which by design are almost pre-selected to be a less riskier patient who is going to be cardioverted. You look at the patient with persistent AFib and compare them with someone who's had a recent stroke within 6 days or so of the AFib presentation, or 6 days, had a recent stroke within 6 days and had a history of AFib, non-valvular AFib in particular, the risk of finding a left atrial thrombus goes up from 14 to 15%, as high as 43%. So the point is that patients who present with AFib and stroke, they're going to be at high risk for have left atrial thrombi, i.e. possibly the need for further imaging. Clots are not seen 100%. It raises the possibility that other things could have caused it. So if you have a imaging for the left atrium, you certainly want a comprehensive test to look for other competing potential causes for thromboembolic stroke in your patient. So in addition, if this left atrial appendage led to clots, you're going to need indexes beyond just clot itself, since 100% are not going to have clot to show you that was the cause, to show you that the left atrial appendage is a potential culprit, namely left atrial appendage function. And that's what we're starting to do on our reports to try to get some idea to our stroke doctors that, yes, the left atrial appendage, despite having no clot, is at risk for having clot formation because it's dysfunctional. So we need imaging modalities that do this, and that's what TE can help. Clinical predictors of stroke in AFib patients that are not anticoagulated have been well documented. CHF, 5.8 times greater risk. Prior stroke or TIA, 4 times greater risk. And this is no more than a CHA2DS2-VAS scoring system. It turns out, though, when you map on imaging criteria onto the CHA2DS2 scoring system, the imaging criteria, stroke, spontaneous echocontrasts, etc., will actually become more positive predictors of subsequent stroke. Transthoracic echo still plays a role, and in fact, I think the majority of patients should have transthoracic echo present with AFib and potential stroke. When to use it, if you think that it's going to make a decision whether you're going to anticoagulate or not the patient, the timing of that anticoagulation, whether you're going to proceed on with TEE, or potentially do left atrial appendage occlusion, I think a transthoracic echo is needed. If LV systolic dysfunction is likely, transthoracic echo can obviously handle that question and is needed. A stenotic mitral valve suspected, maybe by exam, transthoracic echo is needed. And sometimes we're considering cardioversion. If the atrium is gigantic, we sometimes opt not to. If you're going to use the transthoracic echo to make that decision, then it obviously should be done. So there's a lot of reasons to still proceed on with transthoracic echo, even in patients that you're going to do TEE. This complex study looked at left atrial volume indexed to body surface area and looked at ejection fraction in a cohort of patients to see if you could predict the presence of left atrial appendage thrombus in atrial fib. And what the bottom line was, if you had a normal ejection fraction, 55% or more, you had a normal left atrial size, in this case, a left atrial volume index less than 28, the finding of a thrombus on TE was going to be very low. So transthoracic echo helped to predict that the chances of finding a left atrial appendage thrombus was going to be low. On the flip side, if you had low LV function, EF less than 55, if you had, at this time, the index for enlargement of the left atrium was an index of 28. We now move that up to 34. But it's saying this, if you have left atrial enlargement and reduced ejection fraction, 16% of those AFib patients had left atrial appendage thrombi. So a potential role for transthoracic, when you get a report back, the EF is low, the left atrium is enlarged, that's a patient progressively is going to have a higher risk for having clot than someone where all of those are normal. So then transesophageal echo, coupled to that transthoracic echo, may play a role to look for that if it's going to make an impact on your subsequent anticoagulation management. Let's take a clinical case. So you have CHA2DS2-VAS 2 to 4. This patient is, of course, at risk for stroke with AFib, non-valvular, and we would recommend in general anticoagulation, but say this patient had intermediate risk, a relative contraindication by Hasblad, or other things outside the Hasblad scoring system. You did an EF. If it's low, 40%, I think TE would be helpful in that patient because there's a higher risk for having clot. If you were to go to the point of looking at the EF, dividing by the left atrial volume index, and based on the study we just talked about, less than 1.5, that would be a word to you that maybe this patient has a higher risk for stroke because of left atrial appendage thrombi, and perhaps then with a relative contraindication, if you're not going to choose anticoagulation, at least do a TE to make sure there is no clot, because if there is, and that will make you anticoagulate or choose another treatment modality, then TE will make an impact in that patient. So it's trying to stratify that. Left atrial thrombi does increase the risk of stroke, and that's a stupid statement in a sense, but actually there had been very little data in the past on whether left atrial clots actually increase your risk of stroke in AFib. So we did a study early on where we looked at patients with AFib and left atrial thrombi and looked to see how did it compare with other AFib patients without atrial thrombi over time. It was like a 30-month follow-up. There was 43 events in 261 patients. And you can see there was at least almost a threefold increase, 14% per year stroke rate, recurrent stroke rate in patients who had thrombi. So also if these thrombi were relatively large, greater than 1.5 centimeter or mobile, not only is it 5 times greater risk, it could be 19 times greater risk, studied by Lung over a 25-month follow-up. So this is a patient at substantially higher risk, probably going to supersede concerns about relative contraindications to anticoagulation. So this is a finding that's going to probably impact your decision to anticoagulate. Don't think about clots only. Spontaneous echo contrast, which is what we call blood flow stasis, that's how we typically report it in our reports. The risk is almost as high as finding a clot within the left atrium in AFib patients, a non-valvular group or valvular group. Look at here. This is studied by lung. Left atrial spontaneous echo contrast or left atrial appendage spontaneous echo contrast, particularly if severe, at a 14% chance of having stroke per year compared to absence of contrast, a 4-fold increased risk. So almost akin to the 5-fold increased risk for clot formation itself in this group. So that's another thing to consider in terms of decisions to anticoagulate, or even for performance of a Watchman procedure. Spontaneous echo contrast leading to stroke in AFib patients is actually higher than clinical strokes. This was actually an MRI study of the brain, and it found out that if you had spontaneous echo contrast, if it was dense, severe, 17% incidence of having cerebral embolic events on magnetic resonant imaging in Bernhardt's study in 2005 versus just 4%. Not just 4%, but 4%, but substantially higher. Events are occurring beyond what we see clinically. So these patients, even if they're not having clinical events, they're probably having true embolic events that are under the radar, but later on become dementia, other things that we don't want to have happen in our patients. They're very important. Kleeman's study looked at the predictors of high thromboembolic risk that would favor anticoagulation in this intermediate relative risk for stroke, and it was the event rate. So if you had dense spontaneous echo contrast or left atrial thrombus, you can see in this small cohort, there's a much higher over time risk of subsequent death or stroke. This is a composite endpoint versus much less if you did not. So again, it pointed out, just confirming once again what other studies had shown, spontaneous echo contrast, particularly if dense or severe, in the left atrium, is a prognostic predictor for subsequent events, as well as even cardiovascular death. So these patients then, and early on, had a substantial impact. So waiting to treat these patients is you have to make a decision up front, and so you can make an impact in even the short-term prognosis once you have that kind of findings. This is a patient, let's move up the risk of stroke even higher. Why would you even consider a CHAD 6 to do anything? That patient needs warfarin, right? Well, these patients sometimes, even despite warfarin, are still at risk for stroke. So these patients, when they're treated with warfarin, continue to have stroke events, and for various reasons. One is that warfarin is not particularly the most effective drug for decreasing stroke risk in some of these patients, and you may have to consider other options. Also, thrombus in these patients can persist despite warfarin. So this patient can remain still at subsequent stroke risk. So to the extent that you have other treatment options beyond warfarin or considering them, this may be a particular consideration to image. Look at the incidence of thrombus formation over time in patients with AFib. If you look at how long it takes for thrombi to resolve, some took 3 years to finally resolve on subsequent imaging. And I found this too, and people find this quite amazing, that it can take so long. Typically, if it's a small thrombus, maybe 6 weeks. But larger thrombi can take longer to resolve. So the smaller left atrial volume, if the thrombus is echogenic or smaller, a greater chance of resolving in, say, a shorter time frame. But 51% can persist. How could this then make an impact? If you have persistence of thrombi, you may need a more intense INR monitoring. This is just my potential recommendations, 2.5 to 3.5 INR, addition of antiplatelet therapy, consideration of our DOACs, thrombin inhibitors, 10A antagonists to replace warfarin, and left atrial appendage occlusion. And this is a little bit interesting. Should you anticoagulate and put in an occlusion device too in these patients? Not recommending that yet, but this may be a patient then you might want to consider a Watchman approach in that patient. And that's the recommendations for Watchman. Right now, remain patient at high risk for bleeding, that you don't want to continue long-term anticoagulation, but short-term they can take it for 45 days, place the Watchman, and then remove the anticoagulant That is the ideal recommendations for a non-valvular Watchman patient. So this is what the Watchman device looks like. It's a circular shaped structure that you put in an oval shaped left atrial appendage. It just expands to stretch the appendage when you place it there. This is what it looks like. It's a nitinol ring. You have these prongs at the tip of the Watchman that grab onto the inner lining of the left atrial appendage. And this part right here expands to stretch the appendage to maintain it in place. The nitinol ring, and it comes in various sizes. Too small of an appendage, you can't put it in. Too large of an appendage, the device is not large enough to accommodate. So you need imaging to determine that your patient is a potential candidate for a Watchman. Look up here. This is the Watchman being deployed as it's expanding, being open. And then it's going to sit here once this is released right in the left atrial appendage. This is where the prongs are. They grab onto the walls of the left atrial appendage. And at the shoulders where it expands, it stretches the appendage and compresses this device by 8 to 20%. You want that compression to maintain the device in place. You want it in deep enough so it won't embolize. Here's after the release of the Watchman, you can see there's no longer any connection with the catheter. This little stem here is what the catheter was attached to. You can see now it's released, and it's occluding the left atrial appendage. And we look at color. Does it go outside the walls of the device, of the shoulders? And there's no flow around it. So this is an ideal result, completely occluding the left atrial appendage, isolating any clot formation from getting into the cavity and leading to stroke. 3D rendering of a Watchman. This one shows this little shoulder, that little part right up here, sort of extending outside of the actual appendage. So this is a person that we would recapture or the appendage Watchman device and redeploy it because it's too far out. Another thing you're going to start seeing on TE reports is the anatomy mentioned. And we have 4 basic anatomies, and we've added some others. The one that's called the windsock is high risk for potential stroke formation. And this windsock looks like a windsock. If you look at the left atrial appendage on TEE, you look at other ways of imaging it with angiogram, CT, gross anatomy, endocast, it looks like just a windsock. And that's what a windsock appendage is. Increases risk for stroke. Can't come right now, doing a conference. And the other type is the chicken wing morphology. This is what a chicken wing looks like. And this is a left atrial appendage with chicken wing geometry. So you'll hear that term, chicken wing. You see the gross anatomy, CTs, and other things. This chicken wing is probably lower risk, believe it or not, than a windsock for stroke formation. And the chicken wing seems to be the most common. Another is the cactus formation, where it looks sort of like a cactus, where you have these little folds either side of the appendage. You may hear that term, cactus. Maybe less than 10% of the appendages have this morphology. And you see also what we call a broccoli, or some people use cauliflower, where you have all these little undulating pectinate muscles, often a very short appendage on TEE, and gross anatomies, just give you a feel for what that looks like. So those terminologies can have prognostic prediction. This is the effects of a Watchman placed in non-valvular AFib patients with meta-analysis of the trials that were used. These are the trials: Protect AF, Prevail, and CAP registries. We did a composite. All stroke mortality was comparable to warfarin over time. Hemorrhagic stroke, when you put them on the device and remove anticoagulation, you had less hemorrhagic stroke. The overall stroke rate went down, hemorrhagic stroke rate went down, and overall cardiovascular death for unexplained reasons really went down in the Watchman group. And this is a study by Holmes published in 2015. It's a meta-analysis. So just support of the Watchman. So the indication right now is moderate to high-risk stroke patients, CHAD, VAS 3 or greater, with a relative contraindication, say Hasblat score of 3 or so, or any other things that doesn't fit the Hasblat score. We know as clinicians there are things that the Hasblat score does not cover for bleeding risks. And the recommended trials, just as I've shown you very briefly, you have equivalent overall total stroke rate. The Watchman is superior for reducing hemorrhagic stroke to warfarin, and it's superior in this for cardiovascular mortality. So with that, I'm going to come to my conclusion slide, and it's more of a management recommendation slide, I guess, in a sense, too, as to how we fit in imaging. Obviously, our stroke doctors do an excellent clinical assessment of patients who present with potential ischemic stroke, cardioembolic stroke, non-hemorrhagic stroke. So I have no recommendations more than what they normally do. They do head CTs, MRIs, ECGs, chest X-rays, carotid ultrasound, etc. I would impact it here. I think transthoracic echo should be done in the majority of our patients, unless you're going to proceed on with TEE for other indications. If TE will capture all and more, typically, of what the transthoracic echo is going to find. And I think that's important. We're looking for various reasons. Cardiac function, left atrial chamber size, mitral valve pathology. They're going to help in clinical risk stratification and also determining whether you want to proceed on to a TEE. If, however, there's a high index of suspicion for a cardioembolic source for your stroke, I don't think you necessarily need to start with a transthoracic. I think it's very reasonable to start with a TE, provided the TE information that we talked about you're going to use in your direct care. And you may find other things you didn't even think about that the TE may reveal. Because we do a comprehensive approach on 99.9999999% of the patients. So when you order a TE, we're not just going to focus on the left atrium. We're going to look at all those other things, too, that potentially may make an impact in your management. So TE directly, nothing unusual about that in a properly selected patient cohort without a transthoracic. And lastly, I would point out, and hopefully I didn't mislead anyone, there really is no good outcome data that if you do any of this type of thing with imaging, TE, you're going to improve the stroke outcome of your patients in a randomized manner. So more data hopefully will emerge, but I think there's some things that are no-brainers. Clots, anticoagulate your patient. Endocarditis, a vegetation was found, treat that patient. So there are going to be things that really these patients will never be in randomized trials. It's just too much clinical information that we would never want to randomize a patient to not having the imaging modality. So with that said, any questions? Thank you very much. It was a pleasure talking to you guys.
Thank you so much, Dr. Stoddard.
All right.
Thank you very much. I do have a question.
All right.
So I was just wondering what the potential adverse events are or risks with the Watchman.
Yes.
I considered this in patients who have cerebral amyloid angiopathy. And of course, I'm always worried about the 45 days of anticoagulation, but their risk for stroke is so high with AFib. But can you give us some information about the risks and adverse?
Yeah, there are potential procedural complications, and that's less than 4%. The just a small subset could have pericardial effusions develop at the time of the procedure, or a very small subset. Embolization of the device, that's been known, also small, and strokes that can occur, but certainly less than 4% or much less for any more serious complications. So the Watchman, I think overall is a very safe procedure. I don't have any cases that I've had an experience of on infections. We've had cases, very rare, where thrombus did form on the Watchman and subsequently had to have further anticoagulation, which resolved without event, and then the patient came off anticoagulants. In terms of your other question, though, about whether you need to be on warfarin or a NOAC or DOAC for 45 days after the Watchman placement, we now have emerged where we're using antiplatelet therapy, aspirin Plavix, clopidogrel. So if a patient that you think could do better on clopidogrel versus, say, warfarin, who you really would like a Watchman placed, like the amyloid patient, that may be an option that we could sit down and talk about and see that would be a reasonable approach for that patient. So there's other ways of getting through that 45-day window where you don't need that intense anticoagulation management that you ultimately want to withdraw anyway.
Thank you. That's great. Another question, if you don't mind, is
Sure.
about, so we have really enjoyed reading your reports on chicken wing morphology and all these others. And we knew that windsock was putting patients at a higher risk. Would chicken wing is the common one. Would that ever be something that we'd worry about with that?
Yes, because left atrial appendages I always worry about, no matter what the morphology is, right? Yeah. But if you had to be put on the fence, that's going to be a less higher risk because they're still high risk compared to a normal person, right? We're just talking about in that AFib population, trying to stratify amongst those people. Yeah, relative to a windsock, less risk, but still risk. So, but if you have, I would not use it to say, okay, I need to anticoagulate because it's a windsock when I think it's high risk to anticoagulate for bleeding complications. If it's a windsock, if it's not a windsock, but a chicken wing. Sorry, a chicken wing. But if it's a windsock, if it's coupled down with a left atrial appendage systolic dysfunction, if there's stasis, spontaneous echo contrast, then you're up the ante so much so that you believing the fact that there's no clot, that this patient's okay, is a misnomer. That appendage is waiting in lure of forming clots and leading potentially to embolic stroke. So I think that that's a patient where you're going to have to, maybe a discussion needs to be had because you're concerned about bleeding risk, whether Watchman should be done or anticoagulation should be done. Maybe some kind of collaborative arrangement to discuss it. But that's a patient I would not just send cavalier along their way because there's no clot and everything's going to be fine and I won't treat it. But I think that's a patient you should consider higher risk for treatment. Higher risk to treat. Higher risk indication to treat.
Got it. Thank you so much.
Sure.
Anybody else have questions for Dr. Stoddard?
Yes. I have a question. I'm Dr. Wang. Thank you for the excellent talk. My question is about the PFO closure.
Yes.
So how to close the PFO? Is it required open heart surgery or just a device?
No, it's all percutaneous. You don't want to send anything to the surgeons. You know that. I would not be talking about it. But there have been PFO closures with surgery. If they have an open heart surgery, they have the PFO closed surgically. So that technique is well worked out if it had to come to that. But it's a percutaneous device, put it into the right heart. You do go across the atrial septum and you do a clamshell occluder to occlude off that channel to decrease any possibility. Now, what I would say to you is that I'm concerned about always intrapulmonary shunting. I always want to make sure that patient doesn't have another portal beyond the PFO so that if you close it, that same right-sided thrombus that came from the IVC, SVC, from the deep veins could make its path to the left heart. So, but outside of that, I think, it can be done percutaneously. Vika Singh is excellent at doing it. I think he is, if I could do my shout out, if you guys are not aware, Vika Singh is one of our structural cardiologists. His skills are impeccable in all of the modalities that we utilize for structural things. It makes me get up and get happy to go do these procedures. So certainly consider it, for sure.
Thank you.
We definitely do. Thank you.
Sure.
Any other questions for Dr. Stoddard? This was amazing, and we so thank you. And we really treasure the partnership. Thank you.
All right, you guys have fun today, and now I got to go back to my day job. Bye-bye.
Yes, thank you. Thank you.
All right.